Okay, good day everyone. We are on our 23rd session of Learning Basic Arthroscopy series of lectures. Today we have a very interesting and not so commonly covered topic, that is non-traumatic pathologies around the knee. But there are a lot of pathologies in and around the knee, so we will try to cover most of the pathologies of the ACL and the meniscus. Please let me share the screen. Okay, our speaker today is Dr. Vineet Thomas Abraham, who is professor of orthopedics at Mahatma Gandhi Medical College and Research Institute, Pondicherry. He has extensive experience in arthroscopy. He has done his fellowship in knee arthroscopy at Ortho One Specialty Hospital and shoulder and elbow arthroscopy fellowship at National University Hospital, Singapore. We have a common supervisor. I myself worked in Singapore, so we have a lot in common. And he is also member of major national arthroscopy societies. Welcome, Dr. Vineet.
Thank you, Dr. Saseendar.
And we also have Dr. Chowdhury Iqbal Mahmood. Please let me share my screen again. Dr. Chowdhury Mahmood is Associate Professor of Orthopedics from Bangabandhu Medical University. He is a consultant arthroscopy and arthroplasty surgeon. He has done his fellowship from Singapore General Hospital and also from Taiwan, Korea, and UK. He has a lot of experience in arthroscopy surgeries of the knee, and he is also a major national and international arthroscopy societies. Welcome, Dr. Chowdhury. It's a pleasure to have you with us. And we have our own Dr. Srinivas Kambhampati, who is consultant knee surgeon from Vijayawada, Sri Datri Center, and myself, Dr. Saseendar, shoulder and elbow arthroscopy surgeon from Apollo Hospital, Muscat. So, welcome, Dr. Vineet. You can go ahead, share your screen, and proceed with your talk.
Okay. Before I do that, I think both Dr. Saseendar and Dr. Srinivas are doing a very good job in conducting these live sessions. I know I just conducted one webinar. I was tired doing that. They are doing it every week, 2 to 3, maybe more also sometimes. It's just a remarkable feat for all the young orthopedic surgeons to learn. Not that we are also very young, we are still learning. Learning never stops. And I really appreciate the effort. And I'm sure all the young arthroscopic surgeons will really appreciate the effort they're taking, because it's not an easy job to take time and do this 2 to 3 times a week, uh, every week for the past 2 months. You're almost, no?
Yeah, more than 2 months.
Oh my gosh, yeah.
Yeah,
So that's excellent work that you're doing, and you're tirelessly doing it, both of you, Dr. Srinivas and you. And you have been there for each and every listening to all of us, and I think gaining lots also. But the effort, time spent, I congratulate both of you on the effort and time spent. So once again, thank you for inviting me. Although Dr. Saseendar has given me a very rare topic, where all rare diseases, I think, which all of us also would have seen only very few cases. And anyway, let's together try to learn something from this and share our knowledge, whatever we have in these cases. I'm sure Dr. Srinivas would have seen more than me, definitely. I'm 10 years, he must be many more years into arthroscopy. So is Dr. Iqbal and Dr. Saseendar. So let's all share our knowledge today on this interesting but very rare topic. I think all these pathologies are very rare compared to the usual ones. So I'll just share my screen now.
Yeah, thank you very much, Dr. Vineet. I should accept that we are all learning, and I accept even more happily that you said we are all young. So that's something good to hear. Thank you.
Yes, we are. Yes, we are. Okay, you can see my screen now?
Yes.
Okay, right. All right, then I'll go ahead and start, because it's going to take, I think, almost a half an hour. So today's topic, what Dr. Saseendar and Dr. Srinivas had put up was non-traumatic knee pathologies. But when I went through it, we decided there are a lot of pathologies. So we concentrating on ACL and meniscal pathologies mainly. As Dr. Saseendar already told, I'm working in Mahatma Gandhi Medical College, Pondicherry, which is in Pondicherry, and it's part of the Sri Balaji Vidyapith University. And I've done my fellowship in Ortho 1 in 2010, and in shoulder and elbow at NUH Singapore. I followed Dr. Saseendar there in 2015. And both of us were trained by Prof. Kumar, I think, there. So these are the topics that we're going to discuss today. I think the more common ones are mucoid degeneration of ACL and the discoid meniscus. The rest of them are quite rare. I think Dr. Srinivas might have seen more cases of the others than all of us, or Dr. Iqbal also. But we'll go through all of them and we'll see. So we'll start with one rare condition. Again, this is hardly we see in practice, but it's important to know it because we need to recognize all these conditions so that in case we see, we can always put a case report and add to the number of case reports which are already there, few case reports which are there. When going through the literature, very few case reports are there, and case series hardly. Only in mucoid degeneration and discoid meniscus, you see case series. Otherwise, most of the other conditions, there are only case reports which have been added on. So ACL agenesis or congenital absence of ACL is a very rare condition. Its incidence is only 0.017 per 1,000 live births. It was first reported by Georgi in 1956. It is isolated can be isolated or with congenital femoral deficiency, DDH or scoliosis. And most of the times it is asymptomatic. Although when you check clinically, the test will be positive, but they won't have any symptoms. And when they present, they have already presenting with medial joint osteoarthritis. So the structures of the knee are formed. Structure of the knee formed during the 7 to 10 week of intrauterine life. Now, once the ACL is absent, it's not there, like it's aplastic, the intercondylar notch and the tibial spine fail to develop since there's no stimulus for them to grow. So they are hardly there. Now, Manner has classified this rare condition into 3 types of dysplasia. One is the hypoplasia or aplasia of the ACL only with a normal PCL. The second type is type 2 is aplasia of the ACL with hypoplasia of the PCL. In type 3, both the cruciate ligaments, that is ACL and PCL, are aplastic. That is the rare one. ACL agenesis, there's no consensus regarding the optimal therapeutic approach, what to do. Most studies, whatever is seen, suggest non-surgical options is the appropriate way to treat these patients, despite these patients developing early OA. And most patients do not develop instability due to compensatory mechanisms and sedentary lifestyle. Most of them have a sedentary lifestyle because they are not so active, I guess. And most of them, unless they are active, they won't have cases of, we won't have cases of instability. So when you look at the MRI, those who present with symptoms, there is apparent absence of ACL. When you see there's no ACL here, you look at the intercondylar notch, it's extremely stenotic. And you look at the trochlea, there's hardly any trochlea, dysplastic femoral trochlea. And the tibial spines are all also hypoplastic because since there's no ACL, there's no stimulus for it to grow. And this case report was reported by Chala J in the HSS journal. Again, he's shown the arthroscopic view of this. When you see it's a very small stenotic intercondylar notch. And if you're planning to do an ACL reconstruction, you have to do a notchplasty before you even attempt it. Otherwise, you won't be able to succeed. And surgery obviously will be very challenging because of the increased tibial slope, hypoplasia of the lateral femoral condyle, and the rounded posterior femoral condyle. And during ACL reconstruction, notchplasty is done to recreate the intercondylar notch using a motorized shaver. Then, if there is a torn meniscus along with it because of the instability, that is addressed either with repair or with resection, whichever was feasible in that situation. And rehabilitation post-surgery is the same. The next condition which I'm going to come across now, I have also seen quite a few of these cases. I'm sure the other panelists also have seen. That is mucoid degeneration of ACL. It is little known pathology, and MRI prevalence is around 5.3%. And it is characterized by infiltration of a mucoid-like substance interspersed within the substance of the ACL. And the mean age of presentation is usually 42 years. The clinical presenting features include pain and limited motion, especially a deep flexion. That means the terminal flexion will be limited. In some cases, in one of my cases, the extension also was limited. And in this also, not all lesions are symptomatic. There are multiple theories why this is occur. It may be because of some synovial pathology. It may be because of traumatic, because of ACL fibroblasts which secrete glycosaminoglycans that are deposited inside the substance of ACL. Because of multiple micro trauma, like in athletes, multiple micro trauma leads to cyst formation in the ACL substance fibers, and which further leads on to development of this ganglion, this type of picture where there's mucoid degeneration. Then, of course, in degeneration conditions like OA, an interesting theory is the ectopic, where ectopic synovial tissue comes and sits in the ACL and causes this degeneration. Then, of course, altered joint mechanics. So all these are theories only. There's no proof that what is exactly the cause for this. So microtrauma can lead to injury to synovial covering of ACL, which has a protective and healing capacity of ACL. So like I said before, the main features are pain in the knee, most commonly posterior, limitation of deep flexion, mechanical block to extension, and occasional swelling and clicks. So when you look at the MRI, you see this typical appearance, where the ACL is broad, the fibers are widened, and there's a space between them, looks like fluid, and T2 weighted looks like fluid in between the fibers. And that's why it's called the typical celery stalk appearance. As the celery, it's got multiple layers like that, the ACL appears to have multiple layers, and it appears more hypo-intense on MRI, both here and here. In the coronal and the sagittal view, it's seen like that, celery stalk appearance. So treatment is, again, controversial. Again, we'll get to it. I'm telling you some literature review also. Arthroscopic debridement and debulking is a good option, but some patients will require ACL reconstruction. Then when you go intraop arthroscopic findings, usually we'll see continuous ACL fiber, increased ACL volume, yellowish colored material, which is expressed on palpation. When you insert the probe inside the mucoid ACL, you'll see some yellow colored fluid coming out sometimes. And then partial resection can be done, and it's called as partial resection or debulking. And if it's the resection is less than 50%, you can get away by just doing a debulking. But if you are ending up resecting more than 50%, then you might have to do a ACL reconstruction. So I'm just presenting one of the cases which presented to me. As it's a 36-year-old lady who had come with pain in the knee since 8 months, pain on deep flexion, but she also had a 5-degree loss of extension, and daily activity was affected because of pain, and she was disabled, definitely disabled, not able to do her activity. And that is one of the indications when you go ahead and do scopy. And outside MRI, I actually reported it as a ACL tear, okay? Because it depends on the quality of the MRI. And sometimes if the radiologists are not familiar with such a condition, they might report it as an ACL tear. But when I saw the patient clinically, I saw that the Lachman test was negative, anterior draw test was negative, and on Lachman the endpoint was hard. So I definitely thought it can't be an ACL tear. So I discussed the MRI with the radiologist, and like I thought, it was not a ACL tear. As you can see, the MRI quality is quite poor. So this is the mucoid degeneration of ACL. The fibers, the characteristic celery stalk is not so obvious, but there's high signal intensity between the fibers. So that is what suggested then that it could be a mucoid degeneration. So ACL appeared hypotrophic and bulky with fibrinous deposits, suggestive of mucoid degeneration. So Once you go ahead, you do a diagnostic scope, you'll see this bulky ACL. You can insert a probe and then you might see fluid coming out. It'll be very hard. The fiber's also hard. So you can use a shaver and use a punch to debulk the ACL. Then the femoral attachment also has to be debulked along with the medial side of the ACL. Then finally, when you do, you should check the extension, complete extension, see if there is any impingement in the notch. So mostly you won't require to do a notchplasty. You can do a soft tissue notchplasty and remove all the excess fiber from the anterior aspect of the ACL so that it doesn't go and impinge in the notch. So always check for full extension before you come out. And try as much as possible not to debulk the whole ACL. So this is again showing partial resection with a basket forceps and shaver, and post resection the ACL has become smaller. It is much more than 50%. So I didn't do a ACL reconstruction, and the patient has done past 3 years. She's been on, follow up and no problems at all, no instability, nothing. So tips of handling a mucoid degeneration is you have to do a very careful debridement. Remove as much as mucinous material as possible while carefully preserving normal fibers. And fibers that impinge upon lateral femoral condyle are the posterolateral group of fibers. And you need to do an arthroscopic reconstruction if 50% resection of fibers is required. Post-operatively, patients are permitted immediate weight bearing because the ACL more than 50% is intact, and you do the strengthening exercises after that. So in some patients, there can be recurrence, and in some patients, ACL tear, especially active people who are involved in sports. So Pandey v. et al., they studied 11 patients and partially debrided 10 and complete debridement in 1. A lot of studies saying that complete debridement also the patients are able to manage somehow after the complete debridement. I think most of these patients which undergo complete debridement and don't require surgery afterwards may be having a sedentary lifestyle, not sports person. And none of them require notchplasty. And mean follow-up of 13.8 months, all patients regained complete flexion and none complained of instability. Whereas in the study by Masahi Kusano, he had only 4 patients. Two patients, primary sitting itself, he did a ACL reconstruction, and 2, he did a partial resection. Both the partial resection came back, and he had to do a ACL reconstruction with hamstring graft. So he concluded saying that consider primary ACLR in young active patients. Ventura D again studied 25 patients, partial resection in 7 patients. This is one of the studies where he's done more of complete resection. 18 cases he's done a complete resection. And he had a positive Lachman test, but a negative pivot shift in most of his patients. And ACLR somehow was required only in 1 young patient. So again, here we can see the complete resection in 18 cases. And still he's managed to show these results. So, but most take home is that in active patients who want to play sports and all, it may be better if you can do ACL reconstruction primarily, but other patients definitely a partial debulking is enough. Now, there is something called as mucoid degeneration of PCL also. It's much more rarer as compared to ACL. And it can produce symptoms of pain on flexion or restricted terminal flexion. Again, there are very few case reports, and some cases, both mucoid degeneration of ACL and PCL can exist in the same patient. And similar arthroscopic findings are there, so I'm not going into the details of it. The thickened PCL with a yellowish hue. And treatment again in this condition is debulking of the PCL, and very rarely reconstruction. So whereas in ACL, it was called as a celery stalk appearance. Here in PCL, it's called as a tram track appearance because of the 2 tram-like structure, tract-like structures around the PCL on anterior and posterior borders, both in the PDSAT view and the sagittal section. So it's called as a tram track appearance in a PCL mucoid degeneration. Now we'll go on to ganglion cyst of the ACL. Again, this is similar to mucoid degeneration, but it involves a more localized area of the ACL. And there are few cases. I think even Dr. Saseendar told me he has seen a few cases. Etiology is unknown, and theory is that repetitive microtrauma, like in mucoid degeneration, causes expansion of both mucin and hyaluronic acid from ligament fibers, thus acting as a potential trigger. And cystic degeneration also occurs. And most cysts are asymptomatic, so you don't have to do anything for them. In some cases, they have vague symptoms like posterior knee pain, limitation of range of movement, stiffness, and swelling. MRI, you see the cystic masses with fluid signal intensity within the synovial layer of the ligament. So this is, now there are various ways to treat this. Okay, this is one study by Chowdhury Quartet. He is published in Journal of Sports Medicine. Here he's got a large cyst here in the posterior aspect of the ACL. And he treated it with CT guided aspiration. You can either do ultrasound or CT guided aspiration. And this is the 2-year follow-up MRI. The size of the cyst has reduced, patient is completely symptom free. So that is one option of treatment. So only symptomatic need treatment. So arthroscopic, of course, give 95% good results and low recurrence rate. CT scan can give immediate relief and less invasive, but the problem is long-term results and recurrence are not known. We have to have more studies to confirm whether just this aspiration is enough. Although you're making the cyst smaller, but the recurrence rate, we have to still find out. Arthroscopic debridement, of course, like I said before, it gives 95% good results. This is published in the Saudi journal. Again, a large cyst of the ACL after debridement. The chances of recurrence are much less after arthroscopic debridement. Now we go on to a condition which is much more common, I think, which all of us would have seen. That is the discoid lateral meniscus. It was first reported way back in 1889 by Young. And the incidence varies depending on which part of the world you are in. It's only 3 to 5% in the US, 15% in Japan, and 5.8% in India. And incidence of bilateral discoid meniscus is between 15 and 25%. And discoid meniscus are more prone to tearing than normal menisci. And instability results because of a lack of normal meniscocapsular attachment. And torn or unstable menisci sometimes are symptomatic, sometimes they are asymptomatic. Again, like the ACL, menisci also form between the 8 to 14 week of the fetal development. One thing is that the discoid meniscus are thicker, less vascular, especially the peripheral area of the meniscus. And they have decreased number of collagen fibers and now have a more disorganized course compared to normal lateral meniscus. Because of this disorganized circumferential network of collagen, the ultrastructure of this discoid meniscus is weakened, predisposing it to tearing. And intrameniscal mucoid degeneration is also common. So Watanabe has classified, obviously because it is more common, 15% more incidence in Japan. A Japanese has classified discoid meniscus. Type 1 is a block-shaped and covers the entire tibial plateau. Type 2 is where it covers up to 80%. And type 3 is the unstable variant. It's also called as a Risberg variant because the only attachment is your Risberg ligament, which is posterior to the PCL, the meniscofemoral ligament. When you look at this, the meniscotibial attachment is completely absent when you compare type 2 or type 1. There's no coronary ligament, no meniscotibial ligaments at all. So it is only hanging by this meniscofemoral ligament, the type 3 variety. Okay, type 1 is the complete, type 2 is the 80%, and type 3 is the unstable one, or the Risberg type. So in a retrospective study done by Klinkele, complete morphology was seen in 62%, associated meniscal tear in 70% of all the knees, and peripheral limb instability was seen in 28% of the discoid meniscus on arthroscopy examination. So there's a variable presentation depending on the age, type of instability, and tear. Torn or unstable meniscus can present with popping, snapping. The snapping knee syndrome, which we have heard of, is particularly common in this Risberg type 3. And in patients less than 10 years, intermittent snapping of the knee or may be unable to achieve full knee extension. Older patients, the symptoms are more common, which are pain and swelling with or without mechanical symptoms. So X-ray can help you diagnose in some cases, especially the advanced cases. So what we see is squaring of the lateral femoral condyle, cupping of the lateral tibial plateau. And when you look at the lateral joint line, it'll be more widened as compared to the medial joint, sorry, this side. Lateral, lateral joint line will be more widened compared to the medial joint line. And cupping of the tibial plateau. And when you look at the lateral tibial spine, it will be hypoplastic. These signs are seen in more severe cases. So what is obvious, you always try to look on X-ray as the increased joint space, squaring of the lateral femoral condyle, and hypoplastic tibial condyles. So MRI is a good way to diagnose. Transverse meniscal diameter 15 mm between the free margin and the periphery of the body on a coronal view. And when you look at the sagittal view, there you see this continuity between the anterior and posterior horns of the menisci. This is also called as a bow tie sign. But this continuity on the bow tie sign should be present in 3 consecutive 5 mm sagittal cuts of the MRI. Then only it is called as a discoid meniscus. But MRI has a lower sensitivity as compared to physical examination in lateral discoid meniscus. So what does MRI help you in surgical planning? It gives you valuable information regarding the discoid type, the presence or absence of the posterior attachment, which is important to know. Look for associated degeneration and any associated tears. For asymptomatic patients, observation is the key. We don't do anything for these patients. Some patients might have a palpable knee clunk, which is not painful or limiting. Again, you can treat it conservatively. Again, asymptomatic cases discovered incidentally on arthroscopy are also left alone. We don't treat it. And not diagnosed on pre-op MRI. Again, you go and see it in scopy. Typically are not treated unless tearing or instability is present. So when do you treat this discoid lateral meniscus, where you saw one of the articles quoting when there are tears, and a lot of these patients do have tears, and when their patients are painful and they are unstable, then there's history of locking, then you treat these patients. So key here is meniscal rim preservation, and the surgery is called as saucerization, arthroscopic saucerization of the meniscus. Baratz et al. Has said that after total meniscectomy, contact area declined by 75%. And once you remove the whole meniscus, the contact stresses increases by 235%. So arthroscopic saucerization preserves this biomechanical relationship. So this is a nice article which I think everybody can read. It's a review article published in 2017 by Kocher MS et al. All about discoid meniscus from the history onwards to the treatment. And this is a complete discoid meniscus. You use a punch. You can use an arthroscopic knife. Then always probe the meniscus to find if there's any flap tears. And check whether the meniscus is stable or unstable. And this is after saucerization. Nice peripheral rim of 6 to 8 mm. But if there are tears and it is involving the periphery, then it's better to do a meniscal repair, especially at the capsulomeniscal junction. Post-op rehab without meniscal repair, patient can weight bear immediately, physical therapies after 2 weeks, and return to sports 8 weeks post-op. But if you do a meniscal repair, the patient is given a hinge knee brace with partial weight bearing. Range of movement gradually should increase to full motion. Full weight bearing is only allowed at 6 weeks post-op, and then slowly return to sports. This is a case which I had. A 19-year-old girl presented with pain and difficulty in walking because of the pain, intermittent locking episodes, and she was quite disabled. And MRI was suggestive of a discoid meniscus with a tear of the meniscus, a displaced tear of the bucket handle tear of the meniscus. So when we went in, we saw that the tear was displaced. We reduced it back into the intercolumnar notch, then did a meniscectomy or partial meniscectomy, saucerization. And like I said, it's important to probe the meniscus, look for flap tears. And if there are small flaps, you can leave it alone or do a small flap resection. If there are large flaps, you have to repair it. Augut et al. Reviewed follow-up results of arthroscopic saucerization performed in 11 knees, and the mean patient age was 11.5 years. Mean follow-up was 4.5 years. He had 9 excellent results, 2 good results, and no degenerative changes were evident on radiograph for any patient. Now you see here the mean follow-up was 4.5 years only. When you go up for more follow-up, 10.1 years, there's another study done by An published in Arthroscopy. 48 knees, mean patient age was 9.9 years. Mean follow-up was now 10 years. Now he noticed that degenerative changes in 23 patients managed with saucerization alone. 39% of those managed with partial meniscectomy with repair, and 88% with subtotal meniscectomy. So doing a subtotal meniscectomy is a very bad idea, especially at 10 years follow-up. 88% will develop OA changes. So technical pearls when handling a discoid meniscus is you should have all the armamentarium. You should have all the arthroscopic basket, the straight one, backbiting one, the curved ones, meniscal knives, and shavers, of course, both the 4mm, small one, big one, 4mm, 5mm, and meniscal repair devices to repair the peripheral tears if encountered. And a smaller scope also might be helpful. And saucerization should be performed cautiously and meticulously. There's always an eagerness to remove more. So you should be very careful not to remove too much. And remember to maintain a 6 to 8 mm peripheral rim. And post saucerization, peripheral rim is probed and evaluated for stability. Small leaflets are excised. Larger leaflets of the same size, we do a meniscal repair. Now we come to, now that was about discoid meniscus or ring meniscus, again a rare variant, very few case reports. And Noble described it in 1975, which was an incidental finding during autopsy. So what is it? Actually, it is an intermeniscal bridge which extends between the anterior and posterior horns of the meniscus, forming a complete. So the meniscus looks like so the empty center followed by a ring of meniscal tissue. Again, the lateral meniscus normal. Here, the lateral meniscus, you can see the anterior horn and the posterior horn, then this connection in between. And that is why it's called as a ring meniscus. And this was described by Iqbal. Nice diagram is drawn in the skeletal radiology journal. There are some reports of asymptomatic ring-shaped lateral meniscus, but 3 symptomatic cases in both meniscal cysts arising from the ring-shaped lateral meniscus was the cause of the symptoms. And Monlu et al. Proposed that actually it should be part of discoid meniscus and it should be the 4th variant. Okay, but it's still considered as a separate entity. So this is the discoid meniscus, ring-shaped meniscus, which is seen here. And this is a large cyst associated with it. Again, ring-shaped meniscus from extending from anterior to posterior bow tie sign. But the difference is here you may not see it in all the cuts. I said at least in 3 consecutive cuts, you have to see it. 5 mm cuts, you have to see it to be called a discoid meniscus. Here it may not be seen in all the cuts. So that's how we differentiate it from a discoid lateral meniscus. This is a picture showing continuous meniscal tissue from the posterior horn to the anterior horn of the lateral meniscus. And the cyst can be decompressed through the tear and a repair is done. So in conclusion, the inner portion of the ring meniscus is located in the medial portion of the lateral compartment, which is different from so you cannot confuse it from the bucket handle tear of the lateral meniscus, where the displaced fragment most commonly will be lying in the intercondylar notch. Here, it is attached both to the anterior and posterior horns. In coronal plane of the MRI, you can see inner portion of the ring-shaped lateral meniscus is a reflection of the normal C-shaped meniscus, thus making the mirror sign and the central bow tie sign, which I already showed you. Asymptomatic cases are left alone. Now we come to another very rare condition. It is even more rarer than ACL agenesis. It's called as meniscal agenesis. And here I found a case report where it was associated with a TAR syndrome. That is, TAR syndrome is thrombocytopenia and absent radius. And on arthroscopy, both cruciate were absent and nearly absent menisci were present in this particular patient. And the child presented with genu virum and they tried to do an osteotomy at 5 years, but there was a recurrence. So they did a repeat osteotomy at 14 years. So we can't do much for these patients except for osteotomy to correct the deformity. Now we come to one more condition called as a double-layered meniscus. And this meniscus is extremely rare. The prevalence is again only 0.06% to 0.09%, includes both upper additional and lower normal meniscus. And it is usually mobile. This upper additional meniscus is mobile and usually problematic, and rarely displaced and flipped over the intercondylar eminence of the tibia, making the bucket handle tear. Clinical features, they may be asymptomatic or symptomatic, but all reported double-layered lateral meniscus till now are symptomatic. And symptomatic include pain, effusion, and mechanical symptoms like clicking, giving way, and locking. Symptoms were significantly improved in all patients by resection of the hypermobile upper accessory meniscus. So this is the upper access. Normal meniscus will be present, and on top of that, you will have this upper accessory meniscus. That's why it's called as a double meniscus. And this upper meniscus usually won't be full. It will only be half, and it'll be causing problems. Okay, here again we're seeing in all these sections, you can see one layer here and one below. Again, same here, and from the posterior view also, two layers of the meniscus, sagittal view also, one up, one below. That's why it's called as a double layer meniscus. This was reported by Kim S.K. in the 2016 journal. On arthroscopy, this was reported by Fukuda A. This is the accessory meniscus, and this is the double. This is normal meniscus below that. This is him probing that meniscus, the accessory meniscus. This is the one that sometimes causes pain clicking, and so you can easily resect it and the symptoms disappear. Here there was also a meniscocapsular separation, so he's done a repair also. Now we come to the last rare condition. Okay, meniscus extrusion occurs due to substantial disruption of the main circumferential collagen bundle fibers in the meniscus. And tears resulting in extrusion, the most common is the meniscal horn or the root tears. They are the ones that most commonly result in the meniscus extrusion. And radial tears of more than 50% and large complex tears can also lead into meniscus extrusion. And meniscus extrusion result is the loss of the ability of the meniscus to resist hoop stresses and biomechanically overload the joint articular surface. Now, what is significant? Some reports say more than 2 mm, some reports say more than 3 mm and should be treated. Many studies, it has been shown to precede cartilage loss and OA changes. And here, unlike other places, it's a medial meniscus extrusion is more common compared to the lateral meniscus. And it may be related to the anatomical structures and the medial meniscus being the point of weight bearing. And tears involving the meniscal root are also significantly related, like I've said before, and seen in 3% with minor and 42% with major extrusion. So root tears, and quite often seen with OA changes. Degenerative changes during TKR, TKR, they are seen. All this extruded meniscus are seen when you do an MRI. So this is again published, and you can see the extruded meniscus. This is explained by, this is again gone outwards, away from the central, and this is the bare area where it should have been. Again, in one of the coronal cuts, meniscus extrusion is seen on the side. And if it's more than 3 mm, it's significant. You need to do something about it. And this is by Charanjit Bancha from, again, published in Arthroscopic Techniques. And this is a posterior horn meniscus tear, which is associated with, a lot of these meniscal extrusion are associated with tears of the meniscus. So symptomatic cases with more than 3 mm extrusion need to be treated. And of course, you have to reduce the meniscus and repair whatever it is, whether it's a root tear, avulsion, or a meniscal tear. So I'm not going into details, what are the possible. So these are my references. Thank you.
Thank you very much, Dr. Vineet. You can stop sharing your screen.
Yes.
Okay. That was a wonderful, clear and crisp presentation. Thank you very much. I would like to just recapitulate what you said, just for, just to start the discussion. So you covered almost all the rare and most of the important conditions. And first, you talked about the agenesis of the ACL, which is quite a rare condition. Then come the mucoid degeneration of ACL and the ganglion cyst of the ACL. Yes, I do consider it as a spectrum of conditions with focal involvement at the ganglion, focal involvement being called the ganglion cyst of the ACL, and more diffuse involvement being called mucoid degeneration of the ACL with ciliary stalk appearance. And we did talk about mucoid degeneration of the PCL, which is something I have not experienced with respect to my patients. So that is something interesting to know about. But on the other hand, a lot of times I do get MRIs asking whether it's a mucoid degeneration of the PCL, but those are actually of the ACL. But it happened that sorry, not exactly mucoid degeneration. Most of them are ganglion cyst of the PCL.
Ganglion.
Yeah,
More
but
common in the PCL.
they're actually mostly ganglion cyst of the ACL. But it happened that the cyst is very close to the
That
PCL.
looks posterior. So
Yeah. And if you see the
like in
consistency
the
or
MRI, I think I showed.
yeah, if you see the intensity of the ligaments in the MRI, the ACL is hyperintense, but the PCL is almost always normal. So that is something that needs to be identified more carefully. We should not go ahead with a diagnosis of myocardial degeneration of the PCL and start damaging the PCL. So that's something to be noted. Okay, so we also discussed a lot about the discoid meniscus, which is quite very common. And again, it's very common on the lateral side rather than on the medial side. And there are very important points that are to be considered in discoid meniscus, whether it is asymptomatic or symptomatic. It's better not touch the asymptomatic one, even when you are doing an arthroscopy. And in the symptomatic ones, you need to be very careful to identify the type of the discoid meniscus. You don't want to just do a catheterization in an unstable, the type 3 Risberg type of discoid meniscus. It's not going to serve a purpose. The patient is going to come back with unstable meniscus that is possibly going to lock. So you need to identify the type of meniscus and the more rare condition that the ring meniscus for completion sake, meniscal agenesis, double layered meniscus. And I have seen a patient with a patient came with symptoms of medial meniscus tear, and intraoperatively we sort of found it to look something like double or triple bucket handle tear. There were like multiple bucket handles. So I'm not exactly sure whether that was possibly after your presentation. I'm not sure whether it was a double layered meniscus with a bucket handle tear. That should be
Did it have
something to look into it.
did it have
I have the
something
video.
sitting piggyback on the normal meniscus? And only
Yeah. Basically, what
generally
happened?
it's called as a double meniscus only if it's sitting piggyback on top of it, and is usually part meniscus.
Okay, I think
Maybe
you were
maybe one of the layers could have been also the top one.
okay.
Na?
Yeah. I think in your pictures illustration you showed the piggybacking meniscus to be more on the anterior side, but mine in my patient it was more on the posterior side. It was looking like a double layer, but once we removed the inner part of the bucket, there was the remnant meniscus was showing again two parts. So it was like quite funny. Okay. So again, then we go on to the meniscus extrusion. There is a lot of interest getting into meniscus extrusion nowadays. As a primary pathology, I do agree that meniscal extrusion is not a very common condition, but I think as an acquired condition, especially in osteoarthritis or degenerative meniscal conditions, I think meniscal extrusion is getting more and more identified. It has been common all the time, but it is being more and more identified, or possibly more and more people want to intervene. I think there's a lot of work to be done on that. Okay, that was a wonderful presentation. Thank you very much, Dr. Vineet. Okay.
Have you seen a lot of meniscal extrusions?
Yeah. I do see a lot of meniscal extrusions in the MRI.
Most of them must be because of root tears, no, I think.
Most of them are degenerated knees with associated root injuries, not traumatic root injuries.
We don't know if the degeneration is secondary to the meniscal extrusion or extrusion is, it could have been root injury. These things are not studied that. So most commonly they are associated with degenerate knees. So possibly the root tear has happened sometime, and they're present with degenerate knees. We don't know.
It's still to be confirmed.
Knees, I think.
Yeah, it is still to be confirmed whether the hen came from the egg or the egg came from the hen.
So I think if it's not too degenerative, I think we can do a root repair.
Yes.
Root repair, like I just read one interesting one by Pancha himself, that what I was showed. He does uses an anchor. He uses a mid portal just above the middle meniscus. He uses another portal and angulate it towards the root, and then he passes suture just with an anchor. 3 sutures he passes, double loaded suture anchor, and then repairs it down, ties it down. He gets a very good reduction. Before that, he has made a normal using the ACL jack tibial tunnel, but this is using an anchor as a very good option in root test with meniscal exclusion.
Okay, I think even the distinction between cartilage injuries in the knee and osteoarthritis is not wide anymore. I think it's coming down. The spectrum is actually the distinction is actually coming down. The more and more cartilage injuries of the knee are being considered as multiple cartilage injuries of the knee rather than as osteoarthritis. Most of these knees also have degeneration in the meniscus, and they also have extrusion of the meniscus. When definitive treatment is being planned for such multiple focal cartilage injuries of the knee, it is also very important to address the meniscal issues. Okay, Dr. Iqbal, can you share some of your experiences with respect to these non-traumatic conditions of the knee?
First, I would like to thank Dr. Vineet for a wonderful talk. Rather rare condition regarding rare condition. Non-traumatic knee condition actually is quite rare. But pathology related to ACL and meniscus, actually seen quite a case of discoid meniscus and few cases of ganglion cyst, mainly in the ACL, and others are 2 or 3 cases of mucoid degeneration. That's all. But other condition I haven't seen before. So regarding the ganglion cyst, I have seen some cyst in the infrapatellar fat pad region. The patient came with a outside swelling, obliteration of the hollow on the lateral side, and this kind of patient actually comes to you again and again for knee pain or some restriction of movement or locking, something like that. Then you have to do a MRI or like that. And in that case, I did a MRI and I found a cyst in the infrapatellar fat pad region. And what I did, I go for arthroscopy and decompress the cyst and resect the cyst. Sometimes these infrapatellar cysts confused with the Hoffa's disease. You know, Hoffa fat, sometimes inflammation occurs in the Hoffa fat. It's this is a non-traumatic condition also. And sometimes it's very difficult to differentiate between these 2 conditions. And there are other intra-articular structures which can give rise to non-traumatic knee pain, like plica. There's another common thing, plica, I think. Intra-articular plica, particularly medial parapatellar plica. Sometimes patients comes to you repeated pain or clicking, snapping, or so. In that case, you have to resect the plica also. Sometimes you get the plica during ACL reconstruction or other posterior intra-articularly. And regarding discoid meniscus, I have seen quite a lot of cases in discoid meniscus, particularly the present when there is some types of tear within the discoid meniscus. Otherwise, the symptom is not so common. So in that case, as you said, I do usually socialization or partial meniscectomy, but never did meniscal repair after partial meniscectomy. And another important issue regarding non-traumatic knee pain, I think cartilage lesion. We have to address the cartilage lesion also, because there are many cartilage lesions that is non-traumatic, like osteochondritis dissecans and other cartilage lesion. These are also a source of non-traumatic knee pain.
Okay, thank you very much, Dr. Iqbal, for pointing out very important aspects of these conditions. Now that you have pointed about ganglion cysts, I also would like to share some peculiar experiences I have had with ganglion cysts. I have had two different patients with ganglion. One of them had a ganglion arising somewhere from the ACL or from the anterior horn of the medial meniscus. It was not exactly very clear. And the ganglion cyst was herniating through the capsule of the knee into the anterior aspect, and it was lying under the skin. So basically, the patient presented with a subcutaneous swelling on the anterior aspect of the knee. And in an MRI, there was something like a dumbbell-shaped cyst, which was partially outside and partially inside. The radiologist or myself could not identify a specific attachment of the cyst into the ACL, but it was very close to the ACL. And on probing, even before I debrided, I could see some sort of an attachment to the meniscus. So I'm not exactly sure whether there is a relation between the meniscal cyst and the ACL cyst. I think the pathogenesis is quite different in both of them, but I just wanted to share. The other patient with a peculiar presentation, again, the patient had multiple cysts of the meniscus and also one cyst on the ACL. The ACL cyst was actually very small, but there was a very large multiloculated cyst of the lateral meniscus and the posterolateral region that was herniating through the posterolateral capsule and lying to be a very large subcutaneous swelling on the posterolateral aspect. We went in with a arthroscopy-assisted open posterolateral cyst excision and debridement of the small ACL cyst. I'm not exactly these are not yet reported yet. I have not put it down on paper, but this is something very peculiar that I found. Have any of you had such experience?
I had one case. I've actually published it. Ganglion cyst. I put this thing, ganglion cyst or medical cyst, a dilemma. That is my publication also, a case report. But in that case, it was a ganglion cyst only, extending, like you said, on the anteromedial aspect of the knee, and we actually did a open excision only for that. And it was actually seen coming from just below the meniscus, but when you send it for histopad, it was a ganglion cyst, not a true meniscal cyst. There's a difference also to it when you histopad difference.
Is it really? I mean, how do you actually differentiate between a meniscal cyst and a ganglion cyst? Both are
it is consistency. What they say.
Okay.
Is there any histological differences?
Yeah, that's what I would be interested in.
Yeah, I think there is a histological difference. I can't go into the details of it now. Written is quite some time back, but there is a histological difference that differentiates ganglion cyst from the true meniscal cyst.
Okay, but I mean, as a surgeon, I don't know how a meniscal cyst should be different. I always considered a meniscal cyst as a secondary finding in a meniscal tear. So other than possibly a pseudocapsule, I think I'm not expecting much in that. Okay, that's something we should ponder about. We should look into it.
Treatment is the same.
Okay.
Can I have a question?
Yes, please.
Yeah, what's your experience regarding arthroscopic treatment of Baker cyst?
Vineet?
Arthroscopic treatment of Baker cyst, that is actually, I've done only a few cases, but it is very risky. And and you can decompress the cyst, but chances of recurrence are also higher. You have to go through the posteromedial portal and maybe make a posterolateral portal, but be very careful while decompressing the Baker cyst.
Yeah. What I do, I do a diagnostic arthroscopy to see if there is any intra-articular pathology, I address that pathology, then I do the open resection of the Baker cyst.
Okay,
That
so
is, I think, maybe safer because most of the Bakers are.
There's usually a valve from the cyst into the knee. So if you resect the valve, leave the cyst open into the joint, that should be sufficient. If the cyst is too big, I think open is much better. I think preferred open excision is preferred over arthroscopy.
Yeah, yeah. I have.
Surgeon, you have to be very careful while doing it.
Yeah,
because the chances of the capsule getting attached to the posterior structure is very high. So you have to be, while dissecting, you have to be very careful once you. So before you attempt, I think you should have done a few PCL surgeries and only get done such a thing.
Yeah, I do have some experience with arthroscopic Baker cyst debridement, but very minimal. And I also have experience with the open one. And as Dr. Srinivas pointed out, Baker cyst is basically a valve which allows fluid to flow on one side, but doesn't allow it to flow backside. So it just sort of reabsorbs and becomes a gel. So on the other hand, you have to be very, very careful in trying to identify the valve and possibly enlarging or opening it up, and being very careful with your shaver. Better not use the shaver. It had to be very minimalistic. But this is not a primary Baker cyst. This patient had some other issue. I'm not sure, possibly the ACL or the meniscus, along with which I just went ahead and just sort of opened up the valve rather than actually proceeding with a primary Baker cyst debridement. That I have experience with a couple of open Baker cyst excision for very large symptomatic lesion. I think that would be a safer one rather than, if at all you want to intervene, rather than doing an arthroscopic one, because the risk assessment is very, very high. And that's something. Yeah. With respect to mucoid degeneration on the ACL, I think it was very interesting to note your points that even a complete resection of the ACL in the presence of a mucoid degeneration, it causes minimal disability later. That is something very interesting to know. And with respect,
I was very surprised seeing that paper, and he is quoted saying that he's done more number of total resections compared to this thing, and he's saying my first case series like that, first case report which is quoting more resection, and still he's had only one patient going arthroscopic ACL reconstruction, despite having 18 patients who have gone total resection.
Yeah. I have seen quite a number of mucoid degenerations. As I said, I consider it a spectrum. Ganglion cyst on one side and mucoid degeneration, severe mucoid degeneration on the other side. So it is quite still debatable. I have been considering it a debatable topic with respect to the treatment option, but now after you showed up, I'm still not very happy in debriding the whole ACL being a source surgeon, but we have to look at evidence also. I have done a couple of reconstructions for very severe mucoid degeneration, and I have also done very conservative treatment for some of the smaller ciliary structs or ganglion cysts. That is something very interesting to know. Dr. Srinivas.
Yeah, that's a very good presentation. Thank you very much, Dr. Vineet. Of course, it is a difficult topic to cover because most of them are rare conditions. I have seen some non-traumatic conditions, like Dr. Iqbal has mentioned, plicas and Hoffa syndrome. Synovial chondromatosis also comes with lots of loose bodies, and that's a removal of these loose bodies. And PVNS, pigmented villonodular synovitis, can be localized or generalized. And one rare thing I've seen is synovial hemangioma, which presents as a bunch of grapes. Again, it can be local or general. distributing throughout the knee joint. So this can be treated either arthroscopically, or you can open the joint if it's, if it's a big lesion, open the joint and remove the lesion. Loose bodies. One more thing that can happen, sometimes tricky, is lipoma, because there's a lot of fat inside the knee joint.
Lipoma arborescens.
Yeah. So lipoma
arborescens, no?
No, this was coming from the intercondylar notch area and getting into the lateral compartment. So after excision, the patient's symptoms subsided completely. So these are some of the rare conditions I've seen. I've seen one aplasia of the ACL. Actually, it presented as a unusual presentation. We reported as a case report. Presented with a bucket handle tear. There was a flap tear initially. They usually don't have any symptoms. ACL agenesis, they usually don't have any symptoms because they are born with that. So they don't know they actually don't know what instability feels like. So this patient was fibular hemimelia with an absent ACL. She's about 20-21 years. And presented with a bucket handle tear of a flap tear of the meniscus. So there was already a flap 1 or 2 years before, and that flap has bucket handled. So in such cases, the literature for agenesis is actually a little controversial, whether to reconstruct or not, because we don't know where exactly to place the femoral tunnel in these cases. Because this patient had a meniscal tear, I decided to reconstruct the ACL, and also she had a valgus deformity. So ideally you need to correct the deformity and then do the ACL surgery and meniscus. But because there was a bucket handle tear here, we fixed the meniscus, did the ACL reconstruction, and then shortly later, did the deformity correction.
Okay. For must have had to do a notchplasty, no?
I didn't have to, actually.
There was some kind of notch there, huh?
There was a notch. Yeah, definitely there was a notch. The spine.
Very
they usually have a hypoplastic lateral femoral condyle, hypoplastic tibial spine, and the spine appears a bit flatter, the tibial spine, and notch is present in that case. So I didn't have
it was there.
Yeah.
Okay. That's interesting. Actually, agenesis is very rare and challenging to do also, I think. Use a hamstring or a BTB graft for that?
Hamstrings. I used a hamstring. Yeah.
Hamstring only, okay.
Dr. Iqbal. Yes.
Usually we get lots of TB knee, tuberculosis of the knee, and I do quite a number of synovectomy in early cases of TB knee, and most of the cases they comes to you with recurrent swelling and pain. So what's your take on this treatment? Because in Bangladesh there are many tuberculosis of the knee. Do you do any arthroscopic procedure in TB knee?
In TB knee, I do an arthroscopy, give a washout, do a partial synovectomy, send the tissue for biopsy. It does give symptomatic relief. And then get the. Now we do send the testing for even what drugs are sensitive, and JIPMA has a center where they do all these tests for us now. So we do all these tests and then treat. And they even whether it's knee or shoulder also, they do very well with debridement and partial synovectomy. Shoulder case I did for tuberculosis, get excellent relief, and after starting on ATT, he did very well.
Yeah, that's my experience also. They got relief.
Even rheumatoid arthritis, synovectomy, partial or total synovectomies for rheumatoid arthritis. It used to be more common earlier, but now because of the effective drug management of rheumatoid, we don't see that that commonly.
Yeah, Yeah, I would like to share on both the points. I have very minimal experience with respect to arthroscopic treatment or debridement of tuberculosis knee, at least in my practice. But when I was doing my post-graduation in JIPMO, that is what Dr. Vineet is talking about, the center in Pondicherry, we did see quite a number of tuberculosis of the knee, but our approach was more in terms of mini open synovial biopsy and medical management. And I wouldn't disagree with your plan, because it definitely brings down the load of possibly the inflammatory tissue and also possibly the bacteria. And so it can change the prognosis of the joint a lot, because it's something like in osteoarthritis, you give a shot of steroid in a very elderly patient. Similarly, breaking the cycle of inflammation and chondral damage can very well help the patient with respect to recovery of the joint. That is that's a very important point to note. And with respect to rheumatoid arthritis, yes, I totally agree. Previously, there was a lot of debridement that was happening, but now, yes, debridement still happens for recalcitrant rheumatoid arthritis patients who have been on DMRDs and who have not responded. There is a study that we are working on. It a large set of patients who have been on DMRDs have not responded to the drug, and after debridement, they have responded very well, and the dose of DMRDs also came down.
Yeah. Even rheumatoid arthritis, I've also done a lot of patients and do well with, but most of my synovitis come as chronic non-specific synovitis. A lot of cases where it is chronic non-specific synovitis, but they've got a lot of synovium, and it comes as chronic non-specific synovitis. Even recently, we had a case where we are thinking it's a pigmented billonodular, but it came as chronic non-specific.
Okay. And do you have some long-term follow-up of these patients? They will need long-term DMRDs, or they do better with short-term DMRDs?
I think they have some advanced anti-rheumatic medicines, isn't it? These antibiotics, and most of the treatment of rheumatoid arthritis nowadays is medical. We used to do joint replacements, bilateral knees, hips, shoulders, elbows, but all that has now come down because of effective medical management for rheumatoid arthritis.
Yeah, I think with the advanced management, I think the cost is still an issue in many parts of the country. So when it comes to cost, after the regular DMRD treatment, synovectomy is supposed to help a lot with maintaining the cost and giving good prognosis. But there's no doubt that all the infliximab and all the latest treatment methods have proven to be life changes.
Absolutely. Okay. And then I just come back to that question now. I just found out, I read my article again, the difference between a ganglion cyst and this thing, meniscal cyst, is that meniscal cyst has an epithelial cell lining, which is not there in a ganglion cyst. So although in the MRI, even clinically, if you feel it's a ganglion cyst, but if the histopath report says an epithelial cell lining is there, that means it's a meniscal cyst. So this is histopath features. That's why we asked suddenly histopath features. How is it different? And I was wondering what it is. And this is
just for discussion, or logically, possibly this type of meniscal cyst that you're talking about is possibly the congenital type or something.
No, not a congenital. It was an adult only who presented with this.
We have not talked about any malignant neoplasms inside the knee, isn't it? It's all benign conditions we have discussed. Malignancies are very, very rare, but they can happen from any
synovial cell sarcoma
tissues inside the knee joint. Synovial sarcoma is the most common.
Okay.
And another condition is chondrocalcinosis. I think we must have seen a few of them. Where both the cartilage is all covered with its calcium deposit, meniscus is covered with calcium deposits.
Yeah, seen quite a lot of patients, but most of them present with osteoarthritis, and they usually don't land up in any surgical intervention. Yeah. So there is a question from the audience to Dr. Vineet. Dr. Shariar Pervez, he wants to know whether there is a extra articular association of mucoid degeneration of the cruciate ligaments. Other association of non-articular associations with respect to cyst or ganglion cyst in patients having mucoid degeneration of the ACL.
Usually it will be intra-articular only. Mucoid degeneration is intra-articular. Unless the cyst is very large, then maybe you can feel it on the anterior surface. Otherwise, I've not heard of any extra-articular manifestation.
Yeah, non-knee manifestations.
Sometimes it's a combination of both ganglion cyst with mucoid degeneration. Like you said in your case where you had...
Yeah, no. The question is whether there is an association in extra-articular, other parts of the body.
Outside the body. I have not heard of. There may be other this thing degeneration every other places, but it's knee ACL ligament is different. I think
it's
I do agree with
related to degeneration, isn't it? So even if you're, my thought was even if you are doing surgery, because they are associated with degeneration, I tend to be a little aggressive in debriding the ACL. So you don't have to do an ACL reconstruction in these cases because if the knee is going to be degenerated, you don't want to be excising the ACL and then make it unstable. So I do minimal what is necessary.
Yeah, I do the same.
Yeah. Thanks for. I'm sorry. Please go ahead.
Yeah, I was discussing with Santosh. He said sports person, that there's a problem with sports person. Laymen, I think, who have occasional sport activities, they won't have much of a problem. Sports person, he had a sports person where he did a partial debridement and he came back with a recurrence. Then he had to again dissect it, and that time, of course, he had to dissect the whole thing, and he went in with the idea of doing a ACL reconstruction. Otherwise, in my hands, also most of the patients have done with only partial debridement. Till now, I have done only partial debridement.
In general population, it's usually associated with a higher age group. As you said, in sports person, they come with the lower age group. So in those cases, you may have to,
young people, young and active involvement in sports, you might have to do
Yeah, now that you have pointed this out, I want to share the experience. This one was from Chennai, a 40+ male. I did a minimalistic procedure to start with, but he was having a grade 2 instability, and subsequently he came back with more instability, and I had to proceed with an ACL reconstruction. So I think I would like to point out the instability as an important factor in deciding whether or not you want to proceed with a reconstruction or not. If the patient by history he says instability, that is something that has to be given a lot of importance.
Clinical instability. I mean,
clinical,
what the patient says himself,
Clinically,
after I think the section, there might be some amount of Lachman test positive compared to what it was before. But when the patient has instability symptoms, that's what you're trying to say, no? Then you have to go ahead and do it.
Yes.
See, with mucoid degeneration, one issue is there is it is a differential diagnosis for an ACL injury itself.
Yes.
So if the patient had an ACL injury and a torn ACL, there will be instability. So you have to decide whether it's an ACL injury or mucoid degeneration.
Yes, but this particular patient, as per the history of the patient, he was not able to point out to any surgical episode of injury, and the presentation was very chronic, like the proper classical mucoid presentation, like chronic pain in the knee and mild flexion deformity and unable to completely flex and like squat and all that. But he later turned out to be having an instability also.
If he has clinical instability, you should probably think of doing a reconstruction to start.
Yeah. But initially he did not present with a history of instability. He had a grade 2 Lachman and anterior drawer. Grade 2 is something I thought we could very well conserve in
0.1
a
second.
non-professional person. He's not an athlete or a sports person. He's a sedentary type of person. But yes, after debridement, the remnant ACL can go ahead with further healing, or it can go ahead with further degeneration. That is something which possibly you have to risk. Okay. Yeah, Dr. Iqbal, do you want to add anything else?
Yeah, I just want to add another condition, the Osgood-Schlatter disease.
Yeah.
Yeah, it can be also non-traumatic. Sometimes you will get adolescent patients came with pain, and after a bouts of conservative treatment, they comes to you again and again. So in that case, I also sometimes remove the loose bodies or resect the extra bone arthroscopically. And that's the one issue I want to share.
I have seen a lot of Osgood-Schlatter disease, but somewhere or other, I had never needed to intervene then. Most of them do well with physical therapy. Most of the time, it's like recreational sports person, usually in the children. They have been sedentary, and suddenly at one point of time they start running around. This has been happening repeatedly. Most of them do very well with physical therapy, but I think as per the literature, the options could be debridement, micro drilling, or even regenerative techniques, PRP injection. Basically, there is problem in the tendon insertion. There is some sort of a tendinosis and degeneration that is causing the problem, and some sort of stimulation to let the tendon heal could help the patient if conservative treatment doesn't work. Yeah, thank you for pointing it out. Okay, so is there anything else? Any other questions or any other conditions that we're discussing? I think there are no more questions also. Okay, I think it was a wonderful presentation, wonderful discussion. We tried and discussed most of the conditions around the knee that are non-traumatic. Thank you very much, Dr. Vineet, for making a wonderful presentation, and Dr. Iqbal for coming over in short notice and making a lot of discussion. Thank you, Dr. Srinivas, and thank you, myself.
Thank you.
Bye-bye.
Thank you very much.
See you soon.
Thank you. Carry on the good work.
Yeah, thank you. Sure.
Carry on the good work.
You're doing a great job. You're doing a great job, Dr. Sam.
Yeah. Thank you. Take care. Bye.